First of all, I would like to thank you guys for having me today. And we're going to talk a little bit about the pharmacotherapy of obesity, which is an update, but I'm going to be focusing a lot on the incretin-based therapies. I have some disclosures. I received some grants, research grants from Lilly, Novartis, Novo Nordisk. I'm going to be talking about products made by these companies. However, I don't think anything I say here will be biased. I'm going to strictly be focusing on results of clinical trials. Okay. This is the outline of our presentation today. We are going to start by talking about general aspects and principles of pharmacotherapy of obesity. Then we jump into the incretin-based anti-obesity medicines and finalize with a summary of the presentation. So as you all know, obesity now is considered a disease by the the American Medical Association in 2013. It basically became a classifiable disease. Not only it's a disease, but it's a deadly disease. As you can see here, we see increased mortality with higher body mass indices, both in male and females. And again, the BMI thing is very controversial, but still kind of important because we base our management on body mass indices. So as you can see here, we have diet, physical activity, and behavioral therapy being the mainstay of the treatment. So everything I'm going to talk today, you have to take in consideration that diet and lifestyle modifications are important. So the results of the clinical trials that I'm going to present, most of them are on top of lifestyle modifications, and I would say intensive lifestyle modifications. We consider pharmacotherapy in people who have BMIs greater than 27, depending on the population, definitely greater than 30, and metabolic surgery in people with BMIs greater than 30 if they have a comorbidity. Again, we still use this as a guide for treatment. However, this is a very important concept that I want you guys to remember. Okay, I think this is probably the main focus of one of the main messages of my presentation today, okay, which is the management of obesity beyond body mass index. All right. So you probably know that back in, I think, March 2025, there was a very important manuscript published in Lancet, Diabetes and Endocrinology, with a new proposal. That was actually an expert panel all over the world, 50 world-renowned obesity medicine experts who came up with this, new view of obesity, even in terms of classification of obesity beyond body mass index. Okay, so what they propose in this new classification is, first, we need clinical confirmation of abnormal fat mass, which can be done by different ways, like anthropometric measures or direct methods like bone density scans or DEXA scans, um, um, bioimpedance, and so on. So the first thing, the first new recommendation is whenever possible, get body composition in these patients. You can have like two results out of this. First, the fat mass is actually not increased, and then basically the patient does not have obesity. That's the case for high performance athletes. Or yes, you have an excess fat mass, which leads to the second question. The second question is this person carrying any comorbidity associated with elevated fat mass and obesity? So if you say no, that's the old healthy obesity, which we now tend to call preclinical obesity. And if you say yes, then you have a case of clinical obesity. And clinical obesity could be anything. It can be a person who has obesity and high blood pressure, a person who has obesity, dyslipidemia, osteoarthritis, fatty liver, and so on. Okay, so it's very important to classify and stratify risk correctly in these patients. And why is that? Because your treatments now are not necessarily focused on weight. Okay, our focus now will be targeting the weight and those specific complications of obesity whenever possible. Okay, so this is a very important concept, which has been dictating how the clinical trials are actually designed these days. So we have certain indications for certain medications that have been shown in clinical trials to be addressing those complications of obesity. Okay, so this is a very important concept. It's not all about weight, it's about comorbidities and weight. I can trace a parallel between this new concept and what happened with the management of diabetes, which became less and less glucocentric, and now is more dictated by whether a patient has congestive heart failure or obesity, even in the context as kind of a complication of the type 2 diabetes, and so on. Okay, obesity is following the same rationale. So keep this in mind whenever you see your patient, because again, your selection for the management of obesity in a certain patient will depend on the comorbidity. All right. So I want to pause and see whether you guys have any questions about this. This is a very important concept. Okay, I'll move on. So principles of pharmacotherapy. So in general, anti-obesity medicines are indicated when diet, exercise, and lifestyle changes fail. Again, with this new concept, I would kind of, take this statement with a grain of salt, a grain of salt, okay? Because again, depending on the classification of the patient, probably, you always implement lifestyle modifications, but I don't think we should be delaying treatment, waiting like forever for a patient to respond or not to lifestyle modifications to implement a treatment plan depending on the comorbidities. Okay, the classical indications for anti-obesity medicines: body mass index greater than 30, or a BMI greater than 27 with comorbidities, greater than 27 in certain ethnic groups like South Asians. People who take anti-obesity medicines, you have to keep in mind that the response is not the equal for all the patients. So some patients actually might even gain weight while on an anti-obesity medicine, which makes us very cognizant and very careful about the follow-ups. So whenever you start weight management, an anti-obesity medicine for a patient, you have to assess the response in 3 to 4 months. Okay, and of course, if the patient does not respond to that medicine in 3 to 4 months, you can consider stopping, continuing, changing the dose, or making or giving like medication in combination. Okay, of course, today we are seeing more people taking the incretins, the incretin-based therapies, and you know that these medicines, you typically start at a low dose and then you go increase the dose over the course of a few months. Okay, so for these medicines, definitely you have to wait longer to make an assessment of response. Okay, but it's still worth talking to the patient, in a monthly basis to assess tolerability. So that's what I do when I prescribe incretin analogs to my patients. I basically have a plan for escalation of the doses. I tell the patient that, and this escalation of doses typically lasts like 4 weeks, right, for any given dose. I ask the patients to send me message in my chart or call my office to see whether these patients are tolerating the medicine. And then if the patient is tolerating, we go to the next dose. Okay. I also work at the VA. At the VA, the pharmacy service does that. They get in touch with the patients every month for the escalation of the dose, and basically they up the dose until the patient reaches the highest tolerable dose. And when the patient is on the highest tolerable dose, I basically take over. That's what happens in the VA. So I'm kind of mentioning this because the titration of these medicines can be a little challenging, and the system has to adapt to do this in an efficient way, in a way that's not overwhelming to the providers. So, what are the classic weight loss goals? So success is defined as losing at least 5% of the weight and maintaining the loss for at least 1 year. Again, I don't think this is a good definition, but that's what's still out there. Um, um, why 5%? Because over and over, 5% weight loss has been shown to at least reduce metabolic risk, like the incidence of diabetes in prediabetes. In many cases, you actually need to lose more weight. These are the cases. This is the case, for instance, for patients who have obstructive sleep apnea, who typically need to lose more than 15 to 20% of their weight to have a good response in regard to the obstructive sleep apnea. Okay. Um, Problem with obesity uh, is that many patients, they can lose weight rather easily. However, they are not capable of sustaining the weight loss. All right. And again, anti-obesity medicines can be very helpful in maintaining weight loss in this patient. So anti-obesity medicines help with the recidivism after weight loss. Now, these medicines, and there are several. I'm not gonna go in detail on this complicated slide, but what I want to highlight here is that the vast majority of these medicines, the older medicines, the phentermines, the combinations of phentermine to pyramate, the combination of bupropion and naltrexone. So these are older medicines, okay? And the newer ones, the incretin analogs, they all work in the central nervous system, and they do different things. They definitely suppress appetite, but they can also work in other pathways that are, for instance, associated with food preferences, food cravings, which leads to some very interesting like research questions, such as the use of incretin analogs for drug abuse disorders. For instance, there is like great interest in studying the incretin analogs in drug abuse disorders, including alcohol abuse disorder. So again, very marked central effects, even though some of these medicines also have, as you may know, peripheral effects, mostly in the gastrointestinal tract. We do have several medicines now that have been approved by the FDA for the management of obesity. So the very first one was Orlistat. That was back in 1999, lipase inhibitor. Again, that was approved for long-term treatment of obesity. Then we had to wait several years already in in the first decade of the 21st century to have newer medicines. That's the case for liraglutide, the combination of topiramate, phentermine, naltrexone, bupropion, which again they have their own different mechanisms of action, as you can see in the slide. And more recently, we have this very potent incretin analogs, semaglutide and tirzepatide. Semaglutide being a GLP-1 agonist, tirzepatide being a GLP-1 slash GIP dual agonist. Semaglutide can be used subcutaneously, and now we have an oral formulation of semaglutide that has just been approved. In these medicines, I mean, semaglutide, tirzepatide, they have been actually revolutionary for many reasons. They are potent medicines for weight loss, but also they can target different complications of obesity, as we're going to see reviewing the results of the clinical trials. The FDA also approves certain anti-obesity medicines, mostly the sympathomimetics, for short-term treatment of obesity, which today, to be honest, doesn't make any sense. That's the case for phentermine. Okay, it doesn't mean that you cannot use phentermine long-term. Well, phentermine is available in the combined pill with topiramate, which is approved by the FDA for long-term treatment of obesity. Phentermine has been in the market since 1959. It's safe. Okay, I think it's still one of the most prescribed anti-obesity medicines in the market. It's not associated with dependency, as many people sometimes many providers are concerned about phentermine. Of course, it's not a medicine for everyone, but again, it's safe, it's cheap, and for some patients whose concern is mostly weight, probably it's still a good option for these patients. But again, they are officially only approved for 3 months, but you can use it, this phentermine for a longer period of time. You have to be careful though, because in some states they enforce the 3-month rule, and you might get into trouble with the local pharmaceutical council if you prescribe phentermine longer than 3 months. That's not the case of Iowa. In Iowa, you can prescribe this long term without a problem. But in some states, I think Ohio, that's one state I know, you get dinged if you use this chronically. And of course, how they know, right? It's a controlled substance. So this graph shows basically what I kind of described in my previous slide. We have several medicines being developed over the years, and again, more recently, we have medicines that became very potent in terms of producing weight loss. Okay. So from orlistat until liraglutide and everything in between, the best weight loss we could get was anything between 5 and 10% of the weight. Of course, some patients respond better than others. Other patients do not respond at all. So I have patients on phentermine who lost a lot of weight, and again, probably we don't need to make any changes on the medication, but again, today we do have those two medicines in the market, semaglutide and tirzepatide, that are revolutionary. The higher dose of tirzepatide, for instance, produces weight loss that is similar to what we see in some patients taking after a sleeve gastrectomy. So definitely very potent, and there are other medicines in the pipeline, even more potent, reaching weight loss in excess of 25%, which is getting closer to what you can get in terms of weight loss after a gastric bypass. So again, if you think about weight, these medicines are becoming very, very, very potent, and they're very effective. Now, I want to focus on the incretin-based anti-obesity medicines. And again, I want to go back to that first concept we discussed. Okay. I just told you that the newer medicines are very effective, very potent. You can get 15 plus 20% plus weight loss. Okay. However, that's not all the story. You need to go back. You need to classify these patients. You need to know what complication a patient has and try to tailor, to individualize the treatment based on the comorbidities. Okay, it's not all about weight. It's about health and comorbidity management. So, starting with semaglutide, it's a glucagon-like peptide receptor 1 agonist. As I mentioned before, it acts in the brain to reduce appetite. It also, in many patients, it changes food preferences and cravings. It's a very common report in these patients that they don't have food noise anymore, so they don't think much about food. It also acts in the GI tract by slowing the gastrointestinal transit, slowing down the gastrointestinal transit, which by itself creates some sensation of satiety through some afferent neuronal pathways that link the GI tract to the brain. These medicines have side effects, and the list is long. Again, there is even different ways to look at a side effect. So, but again, these are very typical from these medicines, from semaglutide, liraglutide, anything in this class of medicines. Abdominal pain, nausea, vomiting, constipation, diarrhea. Very important, if a patient has diarrhea and let's say is vomiting, it's very important to make sure the patient can keep up with hydration by mouth. If the patient cannot keep up hydration by mouth, probably you should be telling this patient to go to ER for IV fluids, or at least for consideration for IV fluids, because dehydration in the setting of semaglutide use can actually cause acute kidney injury. Okay. Semaglutide, GLP-1 agonists in general are also associated with gallstones, hypoglycemia, mostly in patients who have diabetes and are taking other medicines that can cause hypoglycemia, including insulin. It's well described side effect tachycardia. However, I don't think you should refrain from using semaglutide in patients, for instance, with atrial fibrillation. I don't think it will increase the risk of malignant tachyarrhythmias. Again, that's something you should be aware of. And of course, if there is any questions, and sometimes you have questions, I have patients with cardiomyopathy. I reach out to the cardiologist and get clearance to use this medicine. But typically, it's not a big problem. So it can aggravate diabetic retinopathy. There is this condition called non-arteritic anterior ischemic optic neuropathy that has been described more often in patients taking the GLP-1s, the incretin analogs. I think this is rare. I tell my patients, if you have any trouble with your vision, stop the medicine, let me know, then we'll send you to the eye clinic. And of course, pancreatitis, a history of pancreatitis is a relative contraindication. It's not an absolute contraindication. There is more pancreatitis in patients who take these medicines. Pancreatic cancer does not seem to be a problem, by the way. The absolute contraindication is the history of medullary carcinoma of the thyroid or multiple endocrine neoplasia type 2 that has medullary carcinoma of the thyroid in its in the syndrome. So does incretin do incretin analogs cause medullary thyroid carcinoma? This is actually a big question. We don't know. That definitely happens in animals, in rats, but the association between medullary thyroid carcinoma in humans who are taking semaglutide is not clear. But because they saw this very clearly in the animal models, they kept this as an absolute contraindication in humans. Whether this is real, we don't know. Now, semaglutide, we start at a lower dose, 0.25. This is a very ineffective dose. It doesn't do typically nothing in terms of weight, probably very little in terms of glucose control if a patient has diabetes as well. And then you go up on the dose every 4 weeks until you reach 2.4 milligrams. And typically in the management of obesity, you target the highest tolerable dose, even though, again, it's also prudent to check the weight curve. Some patients are over responders to these medicines. And what happens is if they lose weight too fast, they may end up with basically not feeling well to begin with. They feel like, they're hypothyroid, cold, and just like how people after bariatric surgery and massive weight loss feel. They might not feel well, but there is concern for sarcopenia as well, especially in older patients. Okay, so an overview of semaglutide. Now let's jump into the results of the diverse clinical trials. Again, the first interest on this medicine was, does it cause weight loss? Yes. The STEP program showed it very clearly, and I still remember when I saw this graph for the first time. I've been doing this for more than 20 years, and this was wow. 16% weight loss if a patient does not have diabetes. That was unheard of. Okay, very exciting results. And as you can see below, people who were on treatment, 92% of the subjects participating in this clinical trial, they lost more than 5% of their weight. And 34% lost more than 20%. So this is absolutely unheard of. And now, going into the comorbidities, so semaglutide was then tested in patients living with obesity and type 2 diabetes. And in this particular trial, the SUSTAIN 6 trial, they investigated whether semaglutide would reduce the cardiovascular risk of these patients, right? And again, as you can see, compared to placebo, okay? Again, back then, we didn't know whether these medicines would be better than placebo, so it made sense to make this trial the way it was designed, so compare with placebo, all right? And there was a 26% risk reduction of fatal and non-fatal major cardiovascular events, okay? In a high-risk population. This is actually similar to what you see with statins, all right? And many of these patients were actually taking statins because they have diabetes. So this is in addition to statins. So again, very important result. So if you have a patient who has type 2 diabetes living with obesity, which is almost everyone, right? Who are at high risk for having a MACE, definitely you should consider this medicine. Again, those results just highlight here, in addition to the reduction in cardiovascular risk, we still get significant reductions in A1C and in body weight. Now, patients who live with diabetes, they don't expect the same type of weight loss. They actually tend to lose less weight than the patients who do not live with diabetes, okay? And just like parenthesis here, but I think this is important as well. Never call a patient obese. Never call a patient diabetic, okay? It's a person living with obesity, a person living with diabetes. First, person first language. Again, big story. It has been shown to reduce stigma. So, which sometimes, if you reduce stigma, you can facilitate the treatments. Let's go back to the clinical trials. Now, this is a very important study, okay? I think this is a hallmark study, actually. In this study, they tested the hypothesis that semaglutide would reduce cardiovascular risk in persons with overweight and obesity without diabetes, okay? Without diabetes. And one interesting aspect of this clinical trial was that they did not implement intensive lifestyle modifications. Everything else I'm going to talk about today will have intensive lifestyle modifications on top of it, which is important. But in this particular trial, it did not. All right? It did not. These are patients who were at some increased risk for MACE, and they were, I think, 75% of these patients were already on statins. And a fair amount of them were they lived with pre-diabetes. No patients with diabetes, but lots of patients with pre-diabetes. And again, a very significant reduction in fatal and non-fatal cardiovascular events, 20%, which is apart to what we get with statins. And remember, this is on top of statins. So you're talking about at least a additive effect of statins and semaglutide. Even though, I mean, the study was not designed to answer the type of interaction. But again, this is a very significant risk reduction in a population who is treated with statins. And interestingly, this effect is independent from reductions in LDL cholesterol. So LDL cholesterol did not change. What changed very significantly was inflammation. So the high sensitive CRP went down by almost 40% in the patients treated with semaglutide. So again, one of the proposed mechanisms, which is different from statins, which explain maybe in part why this medicine worked in this population, is because it might be acting in a different mechanism of action. It might be reducing inflammation very significantly and protecting these patients from having cardiovascular events. So SELECT study, I think this is a hallmark study. Now, we have more recently oral semaglutide in the market. The maximum dose is 25 milligrams, and I think this is the dose that can help with weight management. As you know, there is another oral semaglutide at a lower dose used exclusively for diabetes, maximum dose being 14 milligrams, which typically does not really cause major weight loss. So to achieve weight loss with oral semaglutide, probably you must try the new formulation that can go up to 25 milligrams. And the dose right below 25, even though the dosing in the clinical trial was different, but the dose right below in the oral semaglutide available for weight management is 9 milligrams. So probably not effective. For the oral semaglutide, you should be shooting for 25 milligrams if weight is important. So with 25, definitely you can achieve a similar, it's the weight loss is comparable with the subcutaneous semaglutide, about 15-16% in the clinical trial. Again, this is a population without diabetes. However, as you can see here, the rate of response was a little less in the patients who take the oral semaglutide. So 80% of the patients lost more than 5%. And I basically, trying to compare the two formulations. So in terms of weight loss, quite similar. However, with the oral formulation, 80% will lose more than 5% of the weight, whereas with the subcutaneous, 92% of the patients lost more than 5% of their weight. And that has to do, I think, first, the lower doses of subcutaneous formulation can be effective, whereas with the oral formulation, looks like only the 25% or 25 milligrams is effective. Okay, so when you prescribe or when you think about prescribing these medicines, that's something you have to discuss with the patient. Okay. Many patients are now willing to pay out of pocket for oral or subcutaneous semaglutide. As of now, the oral formulation is actually cheaper. It's $50 cheaper than the subcutaneous, just because, again, it does not need like a pen. And one interesting thing about the oral semaglutide is that the patients must take it on an empty stomach. Very important. It does not work if the patient is not fasting, and the patient cannot drink more than 4 ounces of water with the medicine. If they drink more than 4 ounces, you basically wash out the pill and it doesn't work. Okay, so that's one medicine that you have to use the least amount of water just for swallowing so that it works properly. Now, the oral medication, the oral semaglutide, the 25 milligrams, even though there is no clinical trial attesting its efficacy for cardiovascular prevention, it has been approved by the FDA for cardiovascular prevention. So the oral semaglutide 25 milligrams is approved for cardiovascular prevention. And again, it's important because that's one indication that you can get approval for from insurance. Okay, but why did they approve this thing without clinical trial? Because of the results, in part because of the results of the SOUL study that showed 15% risk reduction of major cardiovascular events in patients living with diabetes. Okay, but again, this is not the weight management semaglutide. That's the oral semaglutide. That's used 14 milligrams maximum dose, only recommended for diabetes. This is not recommended for weight management. All right. So again, the weight management oral semaglutide approved for cardiovascular protection based on the literature from subcutaneous semaglutide for obesity and oral semaglutide for diabetes. Semaglutide also reduces cardiorenal risk in patients with type 2 diabetes and chronic kidney disease, as shown in this flow trial. So there was a 24% risk reduction in initiation of dialysis, a composite of initiation of dialysis, kidney transplant, and reduction of eGFR greater than 15. Again, consider these medicines for cardiorenal protection in patients with diabetes and CKD. Let's see here. Yeah. So what I want, this is again, these are some secondary outcomes of the same study, showing a 29% risk reduction in death from cardiovascular causes and 20% risk reduction in death of any cause in this in the same population. That has been associated with greater weight loss. So the greatest the weight loss in this population, the better the outcomes. More recently, that was also a very exciting result. Semaglutide has been shown to improve metabolic associated steatohepatitis, MASH, and liver fibrosis through the ESSENCE study. Again, we have here basically patients who are taking semaglutide 2.4 milligrams. There was a very significant reduction in the, there was a very significant reduction in our resolution of MASH, 62% versus 34% in the placebo, and with reduction of fibrosis, 36% versus in the semaglutide group versus the 22% in the placebo. And again, huge reductions in C-reactive protein, which most likely is contributing to these results. So just for the sake of time, I'm gonna be a little faster here. Semaglutide has been shown to improve peripheral vascular disease functionally in people living with type 2 diabetes, even though this medicine does not have an indication approved by the FDA for PVD. Now, tirzepatide, basically the only difference is it's a dual GLP-1 agonist and GIP agonist. Side effects are the same. Dosing, of course, is different. We start at 2.5 milligrams weekly, subcutaneously, and reach the highest dose at 15. The Surmount study showed incredible weight loss, like more than 20%. And again, going back to the concept, we need to take into account the comorbidities. It has been shown to reduce obstructive sleep apnea. Obstructive sleep apnea in patients who are willing to use CPAP and or not willing to use CPAP. This is this has an FDA indication, even though every time I try to get these medicines through insurance based on obstructive sleep apnea, I was very unsuccessful, but I think it's worth trying. Tirzepatide has also been shown to improve heart failure with preserved ejection fraction. This is the Summit study. And they looked at a composite of death from cardiovascular causes or worsening of heart failure, 38% risk reduction. However, we don't have an approval by the FDA for this indication yet, but again, it shows that it might be useful in these populations. So the pipeline is vast. As I mentioned before, I would, mention here like 3 medicines that you should keep in the radar that are in late stages of development. One is orforglipron, which is a GLP-1 small molecule oral. Retatrutide, which is a triple agonist, and the combination of semaglutide with congrilantide, which is an amylin analog. So these medicines are kind of close to approval, and again, who knows what's going to be the impact on the market. So in summary, whenever you see a patient living with obesity, try to classify the patient: pre-obesity, clinical obesity. Anti-obesity medicines definitely help to people to lose weight and to maintain weight, which is very important. So lifestyle modification is still a very important aspect of the management. And again, when you think about a prescription, you have to take in account the results of the clinical trials, take in account the FDA approvals, because again, these medicines, they are not all the same. They might produce weight loss in a similar way, but they might have very distinct effects on certain comorbidities. Okay, so don't focus on the weight, focus on the patient in a holistic way. I think this is the newer concept of management, of proper management of obesity in the modern era. So thank you very much. Maybe I have time for a couple of questions. Thank you.
Yeah, we have one online. It says, in patients age 25 or younger, do you use the same parameters for starting a GLP or not? What are your adjusted criteria for this age given risk-benefit profile for weight loss?
So it's approved, right? You said 25 or below?
25 or younger, yep.
Or younger. Yeah, I think semaglutide is approved for patients older than 14, but I would have to check on that. It's approved. Again, we are seeing diabetes more and more in this patient, so it's a good option. We are seeing many of these patients with fatty liver as well. We don't know who will develop or not MASH and cirrhosis. Again, I wouldn't hesitate. But again, you have to monitor, right? One thing that I didn't really mention here, because the literature is very inconsistent, is the potential psychiatric side effects. And this is a type of, time in life that a person might be a little bit more unstable. So the extra caution for this population, I would say, okay, if there are changes in behavior, probably the utilization should be reassessed. But in general, and there are clinical trials. I mean, it's not like they extrapolate. There are clinical trials of semaglutide in younger people. showing safety and efficacy. So I wouldn't hesitate to use it with caution.
All right, doesn't look like I have any other questions at this time.
Okay, so I really appreciate the opportunity. And again, oh, I didn't show this because this is always the question. For how long should we keep these medicines? Again, what I can tell is if we stop, people typically regain weight. So there is no position about how long we should be keeping these patients on medicines. That will probably be more clarified in future guidelines. The ACE has a guideline, but the Obesity Society and the American Diabetes Association, they are working on their kind of combined guidelines. So we don't know. The only thing I can tell you is if you stop the medicine, unfortunately, people tend to regain weight. So as of now, for most patients, probably you have to just keep the medicine. Okay. All right. Thank you, guys.
We appreciate you.